Hi, very good evening. So, how are you all doing? So, morning we tried a lot many times. In fact, I tried a lot many times, but I couldn't succeed in streaming live. So, I had to postpone my session. But somehow I couldn't get this idea of live streaming in Facebook, and not even one of you suggested me the same. But later, then I decided that whenever we have an issue with YouTube Live, we'll proceed with Facebook Live. That I'll inform you then and there itself. Okay, right. So we'll try to have two sessions today so that we can cover our morning MCQs as well as some self-assessment questions also. Right. So we'll try to do it as fast as possible so that we can complete off two sessions by 9:30 or 10 p.m. maximum. Right. So first we'll start with. Okay, before that, a very good evening, all of you. Hi. It's been more than 4 to 5 days, right, since we have been live. I hope you have the soft copy of the questions which I posted in Google group last night. So these 10 questions we shall discuss first. We shall complete off these 10 questions and then we'll proceed with the SAQs, right, in a separate session. So, coming to the first question, the drug of choice, since you have asked me to do more of basics, I have incorporated micro and pharmacology today. So coming to the first question, the drug of choice in management of a patient with acute allergic reaction involving bronchospasm and hypotension is options epinephrine, aminophylline, dexamethasone, diphenhydramine. So which is the right answer? And why is it the right answer? The drug of choice in management of patient with acute allergic reaction involving bronchospasm, laryngeal edema, and hypotension. So we have this type 1 hypersensitivity reaction, anaphylaxis, isn't it? Where you have characteristic findings such as hypotension and associated shock. There is even laryngeal edema and bronchospasm. So because of this laryngeal edema, it's a life-threatening condition where there can be a lack of patency of your airway, isn't it? So what is the agent which is preferred in this kind of emergency? Dexamethasone, okay, epinephrine, okay, we have mixed opinion. Some say A, few of you say C. So which is the drug of emergency, which is the drug which is commonly used in any emergency? So dexamethasone, it's a glucocorticoid. Diphenhydramine, it's an antihistamine, right? So even these drugs are used for treating allergies. But the emergency drug which is commonly employed is adrenaline. The concentration of 1 milligram per ml or 1:1000 ratio. It can be both. It can be either 1 milligram per ml, both almost the same, right? So epinephrine is a drug of choice in case of emergency, which relieves bronchospasm, which relieves laryngeal edema, and which corrects this hypotensive state, right? So option A is the right answer, and the concentration which we are using is 1:1000. In case of local anesthesia, what is the concentration of adrenaline that is used? Hi, very good evening. So what is the concentration of adrenaline used in local anesthesia? It's 1:80,000 to 1:1 lakh, isn't it? Yeah, good. Anyways, we have discussed all this in detail in local anesthesia calculations. You can refer that for more information, right? Yeah. Approximately in one cartridge you will have 18 micrograms of adrenaline, right? Yeah. So it is approximately 1:80,000 or 1:1 lakh. So the concentration which is used here is 1:1000. And as Regina has asked, we do have some exceptions, but in general, the mainstay management is providing adrenaline, right? It can be given subcutaneous, it can be given intravenous, even in emergency, even in extreme cases. To revive a patient, we even give intracardiac, right? Yeah. Different routes of, different portals of entry. Now, coming to the second question. Drugs with what maximum particle size can penetrate cell membrane? So we have options 80 angstroms, 60 angstroms, 50 angstroms, and 40 angstroms. So while going through this question, I was referring to Tripathi. There is a direct statement mentioned in that pertaining to the size of the pores which are present in intestine, and the size of the pores which are present in capillaries, through which various drugs do penetrate. So what should be the size of your lipid soluble drugs? Usually for absorption, lipid soluble drugs have better absorption, right? So drugs with what maximum particle size can penetrate cell membrane? Is it 80, 60, 50 or 40 angstroms? Uh, 60 angstroms, are you sure? In case of acute emergency asthmatic attacks, we use adrenaline. We can use adrenaline as an emergency treatment, but we also have other alternatives like theophylline. Go through the treatment protocol of asthma, you'll understand again, right? So is it 60 angstroms for sure? Okay. Most of the lipid soluble drugs cross the biological membranes by filtration if the molecular size is smaller than the diameter of pores. It's obvious, right? So the diameter of the pores in the membrane is to such an extent that the molecule which is penetrating through these pores obviously has to be smaller than the size of the pores. And the size of the pores is, I'll just mention it here, pore size along your GI tract. It's 4 angstroms. In case of capillaries, it's 40 angstroms. So these are direct values picked up from your textbook. In fact, these are the things which we might commonly neglect, but you can even have questions from these remote topics, right? In absorption, refer absorption, your pharmacokinetics and pharmacodynamics, as the general pharmacology topic, you'll have a much clearer picture, right? They are given this representation, schematic representation, as well as the size of the pores, and it's mentioned clearly that the pore size along your intestine, lining your intestine, is around 4 angstroms, and capillaries it is around 40 angstroms. So option D is the right answer. Clear? Yeah, hi, very good evening, all of you. Now let's move on to the third question. A highly ionized drug is excreted mainly by kidney, crosses the placental barrier easily, is well absorbed from intestine, is highly protein bound. So which is more appropriate for a highly ionized drug? Yes. The highly ionized drug. Okay. Once you start looking at the differences between non-ionized and highly ionized drugs, we just mention them here. Okay. When we compare non-ionized with ionized, which one do you think is more lipid soluble? Ionized or non-ionized? As Regina has rightly mentioned, non-ionized, they are highly lipid soluble, isn't it? Hence they are well absorbed from the intestine. So non-ionized drugs are lipid soluble, whereas lipid solubility is very poor in case of ionized drugs. So ionized drugs are lipid insoluble. They are insoluble. Now, so coming to the absorption. So absorption has got something to do with your lipid solubility. Remember, to be better absorbed by your body, any substance has to be lipid soluble, and to be better excreted, any substance has to be polar or water soluble. So in the process of conjugation or biotransformation, if you remember, there is phase 1 and phase 2 reactions, right? Oxidation, reduction, conjugation reactions, where these complex molecules are being converted into polar molecules so that they can be excreted, water soluble molecules, so that they can be excreted through kidneys, right? So to be better absorbed, any particular substance has to be, a molecule has to be lipid soluble. To be better excreted, molecule has to be water soluble, isn't it? So they're better absorbed. And poorly excreted, isn't it? Whereas these are poorly absorbed, well excreted. Right? Yeah. Non-ionized or lipid soluble. And coming to the rate of crossing placenta or any barrier, so these cross any barriers well. So placental barrier or blood-brain barrier, right? So better crossing, whereas poor penetrability in case of your ionized drugs, right? And obviously excretion is poorly seen. In fact, the drug is reabsorbed into the body from the tubules, hence poor excretion. Whereas the drug is well excreted, since it is water soluble, it is sent out through your kidneys, through your tubules, right? So highly ionized drugs or polar drugs are reabsorbed by the tubules and hence well excreted. So these are some of the differences between your non-ionized and ionized drugs. Very simple. So coming to the question, a highly ionized drug is excreted mainly by the kidney, right? So option A is more appropriate, as you all rightly mentioned. Next, moving on to the fourth question. Which of the following has true agonistic activity? I mean, in fact, the spelling is wrong there. Which of the following has true agonistic activity? Agonist, right? On beta receptors. So the question is, which of the following has true agonistic activity on beta receptors? Option A, isoprenaline, adrenaline, noradrenaline. Option B, isoprenaline less than adrenaline, less than noradrenaline. And option C, adrenaline greater than isoprenaline, greater than noradrenaline. Option D, noradrenaline greater than adrenaline, greater than isoprenaline. So we have a sequence here between isoprenaline, adrenaline, and noradrenaline. So which of the following has greatest agonistic activity or greatest potency to act on beta agonists compared to the other molecules? Polar is nothing but something which has a charge on it, right? So once it is ionized, obviously it's going to have some charge. So polar molecules are ionized molecules, isn't it? So which of the following has true agonistic activity on beta receptors? So which is the right answer? When you compare isoprenaline, adrenaline and noradrenaline, which among these has, arrange them in the order such a way that so that you can compare their agonistic activity on beta receptors. Few of you say option C, or if you are going with option D. Okay. So let me just write down here. So this is the order of beta agonistic activity, right? Isoprenaline has the most potent beta agonist, is the most potent beta agonist of all the three, followed by adrenaline, followed by noradrenaline. So you can just mention this as order of beta agonist activity, right? So isoprenaline, followed by adrenaline, followed by noradrenaline. So isoprenaline is the most potent beta agonist. Right? So please make a note of it. Okay? Fine. So option A is the right answer. Now let's move on to the fifth question. A patient who is taking carbamazepine is given erythromycin, which can lead to option A, patient complaining of headache and vertigo. Option B, no adverse effect. Option C, larger dose of erythromycin would be required for therapeutic effect. Option D, larger dose of carbamazepine would be required for its desired effect. So a patient who is taking carbamazepine is also given a macrolide erythromycin. This can lead to which are the following adverse effects? So that's the question. How many of you have gone through these questions last night or today morning? Because I've already posted the soft copy there. So that's the reason I'm confidently reading the questions, assuming that you have a soft copy along with you. Good, Regina. Yes, Kedar. Niharika, you say option C. Bernice says option C. Okay, just make a note of it. Erythromycin which is a macrolide, is going to inhibit hepatic oxidation of drugs such as carbamazepine, which is used in treating seizures, if you remember, carbamazepine or theophylline, and also warfarin, oral anticoagulant. So, since erythromycin is inhibiting hepatic oxidation of these drugs, their levels in plasma increase dramatically, as Vegana has rightly mentioned, due to which there can be toxic effects or side effects associated with these medications. In case of carbamazepine, the side effects associated include headache and vertigo, as mentioned in option A. So a patient who is taking carbamazepine is given erythromycin, which can lead to patient complaining of headache and vertigo because of increased plasma levels of carbamazepine, as its biotransformation or metabolism is inhibited by erythromycin, right? So option A is right answer. I know basics, they're comparatively challenging, but keep on trying to answer as much as possible, because only once you make mistakes, then you will have this opportunity to learn and to remember, isn't it? It's not that we all are perfect. We need to go through these things several number of times. We need to master these concepts. It's all about understanding, and on one side of the coin, on the other side, it's also equally about memorizing these concepts, isn't it? So don't feel low if you're not able to answer this. I have intentionally selected a few tough questions from the basic topics, as we have been doing clinicals also, right? So we'll be doing more of basics, and we'll try to improve your confidence levels in the process, right? Also, we'll try to have more videos from the basic subjects, okay? Yes. So option A is the right answer. Okay, we'll proceed with the next question. Fine? Yeah. Sixth one. Now, few questions from microbiology. Borrelia vincenti is always associated with spirochetes, fusiform bacilli, Treponema vincenti, none of the above. So Borrelia vincenti is always associated with yes, responsible for NF. Are you sure it is spirochetes? We have something called as Vincent's angina, right? Vincent's angina or trench mouth. So Borrelia vincenti is always associated with. We have a symbiotic infection which is known as fusospiroketosis. So this is a symbiotic relationship between your fusiform bacilli and Borrelia vincenti. Exactly. I know it's all memory based, but okay. As I said, don't feel low if you're not able to answer right. So Borrelia vincenti is always associated with fusiform bacilli or Fusobacterium fusiforme, and this symbiotic infection is called as fusospiroketosis, right? So this is commonly seen in Vincent's angina or trench mouth, as you are rightly mentioned. Enoch. Good. Okay. So option B is the right answer. So Borrelia vincenti is always associated with fusiform bacilli. This is a symbiotic infection which is termed as fusospirochetosis. Now, moving on to the 7th question. Exactly, Prasanth. It itself is a spirochete. Even Treponema vincenti is also a motile spirochete. We have Treponema pallidum, right? It's also a spirochete. Good. Now, 7th question. The operating temperature in an ethylene oxide sterilization during a warm cycle is. So, what is the operating temperature in an ethylene oxide sterilization during a warm cycle? 20 to 35 degrees centigrade, 49 to 63 degrees centigrade, 66 to 88 degrees centigrade, 90 to 110 degrees centigrade. Yes, Bernice. So what is the operating temperature of ethylene oxide sterilization during a warm cycle? I just mentioned it here, I hope you can see, right? So ethylene oxide sterilization, you have warm cycle and cold cycle. Yes, warm cycle operates between, it's 54 degrees centigrade plus or minus 5 degrees centigrade, right? 54 degrees centigrade plus or minus 5. And cold cycle is between 37 plus 5 or 37 minus 5. Memory based, so make a note of them in your notes, right? As I said, it's better if you have a separate, even now if you haven't placed any separate notes for live sessions, do place one separate notes for live sessions, as we'll be doing more and more live sessions in the coming days, right? So that you can just make a note of all these memory based topics, memory based points. So ethylene oxide sterilization, warm cycle 54 degrees plus or minus 15, cold cycle 37 degrees centigrade plus or minus 15. So this is translating into 49 to around 59 approximately, right? So option B seems to be closer. So option B is the right answer. 49 to 63 degrees centigrade, right? Yeah. So it's option B. Now let's move on to the next question. The retroviruses are characterized by DNA genome, double-stranded RNA genome, provirus phase, both B and C. Hi Akshit. So retroviruses are characterized by DNA genome, double-stranded RNA genome, provirus phase, both B and C. Yes, Manipal, hi. See, as you all know, RNA is always single-stranded, right? So DNA is double-stranded. So retroviruses are those viruses which contain the enzyme reverse transcriptase and which have the potential to convert RNA into DNA, right? So retroviruses are RNA viruses characterized by single-stranded RNA genome. This is converted into RNA-DNA hybrid in presence of an enzyme reverse transcriptase. And from this hybrid, RNA-DNA hybrid, a double-stranded DNA is formed. And the virus containing this double-stranded DNA is called as provirus phase, right? So provirus is nothing but virus with double-stranded DNA. And this provirus DNA gets incorporated into host genome, which is responsible for various cytopathic effects or various kind of ill effects which we see externally in form of either pathologies or in form of either tumors, right? So retroviruses contain single-stranded RNA and they form this RNA DNA hybrid in presence of your reverse transcriptase enzyme, and from this hybrid there is synthesis of your double stranded DNA, and the virus with this double stranded DNA is called as provirus phase. So coming to the question again, retroviruses are characterized by its provirus phase. Option C is more appropriate. Yes. Hi. So Akshit, by the way, Akshit is my student. So he's very enthusiastic and a very good boy, in fact. And he's has a lot of different thoughts altogether that none of us will really dare to think. So he thinks in a different way. And he's, like as I say, everyone is unique. So Akshit is unique in his own way. Since I've seen Akshit for the first time, Akshit is the first time you're commenting. So glad to hear from you, Akshit. Keep going. Now we'll have our penultimate question. The mode of entry of leprobacilli is via GIT, orophageal route, respiratory tract, none of the above. So what is the mode of entry of leprobacilli? GIT, orophageal route, respiratory tract, none of the above. Have you heard of droplet infection? Transfer of infectious material through droplets of moisture from the upper respiratory tract, either through coughing or sneezing. So this droplet infection typically is seen in case of your spread of your leprobacilli. So these leprobacilli, the mode of entry is either through respiratory tract or through skin, but the source is your droplet infection, right? So after the infection, the bacilli are shed in nasal secretions, right? So as I said, droplet infection is transfer of these pathogens through droplets of moisture from the upper respiratory tract, either through act of coughing or sneezing. So the mode of entry of leprobacilli is through respiratory tract. Okay, good. Now let's proceed with that final question. It's an image-based one. I even posted the soft copy. The picture of the same. You can go through that if you have a soft copy. Since I have a black and white image here, I can't really show you, and you can't appreciate the difference also. Or if you want, I can show in my mobile. Okay. By the way, the question is the mode of entry. The culture media used for cultivation of Mycobacterium tuberculosis is. So what is the culture media which is used for cultivation of Mycobacterium tuberculosis? McConkey's medium, Ledlam's medium, Lowenstein-Jensen medium, none of the above. So in the meantime, I'll just grab that pic. Yes. Can you have a look at this? This is the maximum amount I can zoom in. You can see brown granular colonies which are being formed, isn't it? So the medium is green in color, as Abhishek has rightly said. You can see brown granular colonies. I hope it's clear. Right. So this is a medium which is used for culturing Mycobacterium tuberculosis. So the question is, Mycobacterium tuberculosis is cultured in which medium? McConkey's, Ledlam's medium, Lowenstein-Jensen medium, none of the above. Oh, we have answers already. Good. LJ media. It's also called as LJ media, specially used for culturing Mycobacterium species. As you can see, we have brown granular colonies, which is also described as buff, rough, and tough. buff, rough and tough. So that's how it can be even described as, and the media must be incubated for a significant length of time, around a week, because the doubling time of Mycobacterium tuberculosis is. So what is the doubling time of Mycobacterium tuberculosis? Incubation has to be done for at least 4 weeks. And the question now is, what is the doubling time? Doubling time for Mycobacterium tuberculosis. Yes, thanks, Bernice. So what is the doubling time of Mycobacterium tuberculosis? In fact, it can survive for 20 to 24 hours on moist surfaces, and in sputum it can survive for up to 2 hours, I reckon. Yes. No, it's not in days, Deepak. Anyways, the doubling time is, as I said, the incubation has to be done for 4 weeks, but the doubling time of the bacteria is 15 to 20 hours, right? Running out of space. Okay, Mycobacterium tuberculosis. And Meconius media is used for which bacterium? Regina, I have no idea what is blue. We're talking about the colonies. Just focus on how the colonies are growing. They have this characteristic brown granular appearance, which is described as puff, rough and tough. And Meconius media is used for Staphylococcus, and Staphylococci appear as pink colonies. And Ludlam's media, it is a selective media for Staphylococcus. Yes, exactly. Okay. So these are some of the MCQs which I wanted to focus on. I know it's challenging, basics and all, but we'll try to do as many as possible. And this is a time for you, as you have been discussing in group today. Exactly 30 days time. So I made one video relevant to these 30 days, what all you should focus on. That's just about believing yourself and staying confident, and which in turn again depends upon how you plan your preparation now, which is very crucial and critical. So don't worry, you've been working hard, maintain the same pace and consistency, believe in yourself, and all the subjects which you are not really confident in. This is a time where you can focus on for another 10 to 15 days before you start your final revision. Maybe 10-15 days before or after December 15th, you can plan your cumulative revision once again. So all basics, try to focus as much as possible within the span of 1 or 2 weeks, right? So you need any personal guidance, drop a mail, I'll be happy to assist you. And you need any additional support, do let me know, right? And I'm planning to have more live sessions after December 15th. So till December 15th, I'm occupied with some work. So I have to carry on with that, and I have to balance both. So we'll have these live sessions as usual, but after December 15th or 10-15 days before exam, maybe we'll plan more and more live sessions, right? So that we can discuss more and more subject possible. Yes, Prashanti, I would like to post the pic of board in group, but the problem is I've written few in short forms, right? I'm not sure how exactly you're going to get it, because again it will be confusing for you to go through. Anyways, I'll do one thing, I'll just expand these forms, I'll take a pic and then I'll post it in our Google group. By the way, our WhatsApp group is full. It has exceeded, it's now filled up with all the members. It's beyond the limit. So we're having more members, so we're planning to create a new group, or maybe we'll divert everyone to Google group if possible, right? I hope you might have understood now why I insisted on Google group at the first time. Numericals and graph in each session would be very helpful. Okay, Prithvi, sure, I'll consider. Yes. Okay, we'll stop it here. Do you want me to have another live session SAQs or shall we stop here? I mean, you decide based on that we'll proceed. We'll have SAQs for 20 to 30 minutes maximum. Do you want another session or shall we meet tomorrow morning for image-based discussion? So you're not really ready to get fried for another 30 to 40 minutes after this, right? I can understand. Okay, we'll have some image-based questions tomorrow morning, right? Yeah. Okay, fine. So we'll do it tomorrow morning as usual, right? So we are running short of one session this week. I'll see if we can do an additional session or I'll do one recorded video and post it on YouTube to compensate this, right? Yeah. See you tomorrow morning. And love you all, right? And go through that video which I posted yesterday, 30 days before NEET. Try to understand, try to get the gist of it, and please make sure that you do everything in the best way possible and stay confident. As I said, confidence is the key, right? So all the very best. Love you all. See you tomorrow morning, right? Bye. Yeah, good night.